This is Dr. Jean Hubbell from U.S. WorldMeds Medical Affairs, and welcome to the APOKYN Patient Speaker Training Program. We're going to start by a review of the compliance elements of this type of speaker program. The FDA does consider these programs to be promotional in nature. That is because a company, in this case U.S. WorldMeds, is arranging both the content and the speaker. It is not promotional in the sense that we anticipate the speaker to be, quote, selling APOKYN, but rather providing on-label information about the proper use of APOKYN in the treatment of Parkinson's disease off episodes. Of course, again, the main emphasis of any programs like this is the educational value, but it's important that content also falls within the guidelines provided by the FDA and other regulatory bodies for programs like this. So the FDA does hold both the company and the speaker responsible for the product promotional presentations. And speaker presentations are subject to applicable FDA rules and regulations, specifically those that fall under the prescription drug advertising regulations. The FDA does have broad statutory authority to regulate all promotion of prescription drugs and, for that matter, prescription devices as well. And, of course, under this authority, the FDA strictly prohibits any type of false or misleading information. There are potential violations are potentially subject to civil and criminal penalties under the Federal Food, Drug, and Cosmetic Act. Think, though, about the a promotional program like this, a promotional education program like this, and what type of compliance do's and don'ts exist. You can really simplify them. To satisfy the FDA requirements, all presentations must be truthful and not misleading. In particular, the FDA is very clear: do not mislead by exaggerating or expanding the potential benefits of a drug, but rather stay on label, meaning within the context of the prescribing information. Similarly, the FDA is very clear: do not mislead by underrepresenting or omitting mention of key safety concerns. So we call that fair balance. So the FDA's rules and regulations can essentially be boiled down to remain on label, that is consistent with the FDA-approved product labeling in regards to potential benefits and efficacy, and also always provide fair balance by covering all important risks balanced against benefits. And if you use the U.S. WorldMeds approved slide kit and the approved video, you will be satisfying these requirements in providing on-label, fairly balanced presentation. In terms of keeping within the approved labeling, the FDA in that regard is very specific. Stay on label in terms of the approved indication or use of the drug. That's very easy to do in the case of APOKYN, because APOKYN is approved only for a unique population with a subset within Parkinson's disease, and that is for the treatment of off episodes in patients with advanced Parkinson's. It is possible, however, in the context of a presentation like this, that there may be off-label questions. That's actually fairly rare at a patient presentation, but if that were to happen, it's important that you point out that what APOKYN is approved for, and try to address the patient's, in this case, patient's question in a general way, and always advise patients to take their specific situation and questions back to their own treating physician. In terms of fair balance, all presentations must contain a balanced discussion of both the benefits and risks associated with the use of a product. Fair balance specifically then pertains to covering all important safety information, both in terms of content and format. So when we get into the slide deck itself, there'll be several slides that have the word-for-word, on-label, patient version of the important safety information. That always must be shown, so the entirety of the contents must be shown. But the FDA also says be careful about how you format or display such information to exaggerate. We couldn't have slides that had the efficacy of APOKYN in size 50 font and then go to the important safety information and display it in illegible size 5 font. The FDA, even if you had a complete safety information, the FDA would consider that to be misleading formatting because it could not be easily read or understood by others. Fair balance, therefore, is achieved by showing the applicable safety information on those individual slides and the summary slides, and I'll point that out when we go over the presentation. So, key compliance points. All presentations must be truthful, not misleading, and stay on label in terms of the correct use of APOKYN, and always provide fairly balanced information on not only efficacy, but also safety. The U.S. WorldMeds slide deck is designed for this specific use, and it satisfies all these requirements, so all the slides should be shown and discussed. And in fact, you may not realize this, but all companies, including U.S. WorldMeds, we actually submit these materials to that office of the Food and Drug Administration that oversees advertising activities. So this is all on file with the FDA. It is important, if you haven't already done so, to download and review the supporting materials on the website, the speaker website, and available there is also the full prescribing information and also some of the clinical trial publications should you have an interest in it. Also, I'll point out that when you conduct these programs, who just joined?
Yes, I'm sorry, this is Dr. Varga. My computer was down because of the storm, so I'm a little bit late.
Okay. Oh, it's nice to Jean Hubble, Georgetta. Very nice to hear from you.
Good morning, Dr. Hubble. I'm sorry. I mean, for the last 5 minutes, I was trying to log on, and I called Kate. And then last night I downloaded all the slides, so I had them downloaded, but I thought I have to be on the computer, and she said that just dial the number. So I have the slides in front of me.
And that's absolutely fine, and we'll start on the slides in just a moment. Dr. Varga, also on the phone with us today are 3 of our Circle of Care nurses from other parts of the country, from Nevada and Florida. And also one of my colleagues from U.S. WorldMeds Medical Affairs, Whitney Martis, is on the phone with us as well.
Good morning,
Dr. Varga,
yes.
And I was just wrapping up, not with the slides themselves. We'll start that in just a moment, so you'll be in good stead with that. I was just making some general comments about these types of speaker programs. I was pointing out, and you joined at a good time because I was just summarizing my comments. These types of programs, even for patient programs, they are considered to be promotional in nature because a company, U.S. WorldMeds, is directly involved with developing its contents and selecting its speakers. So they are considered promotional, although we are not asking you to sell APOKYN during these patient programs, but the FDA does consider this promotional. Therefore, we've filed all of these slides and videos already with the FDA office that oversees advertising. So it is important to stick to these slides and not supplement or change them, because that would detract then from what documentation we've provided to the FDA. The other thing I was mentioning, Dr. Varga, right as you joined, was when you do these types of programs, these patient education programs, in addition to showing the slides and the video that accompanies the slide deck, in addition to that, your regional account manager will always have with them patient-designed materials. Also, they've been sent to the FDA. That also contains the full important safety information. So if for some reason you either couldn't show the slides, there was AV issues, or you were running short on time, you should always direct the patients to take home the brochures and read through all of the information in the materials, the written materials, including important safety information.
Yes. Okay.
I'm going to go ahead now and move from the review of the compliance elements, and let's go over the slide deck itself. The slide deck is developed in sections. The first section is simply background, very basic background on Parkinson's disease and its treatment. And this is a part of the deck that you can really personalize, and patients, I think, very much appreciate that. That is, you can use your own experience in working with and treating Parkinson patients to help add color to this portion of the presentation. It starts just with a quote from Michael J. Fox at the very beginning, and then also goes quickly into Parkinson's disease itself, not only famous people who have suffered from Parkinson's disease, but how it affects, how many Americans it affects as well, or at least an estimate. And again, you can really use your own language or examples to draw more attention to Parkinson's disease.
Okay.
About Parkinson's disease itself, then, we go quickly into what is the neurochemical problem in the brain in Parkinson's disease. As certainly Dr. Varga and others on the phone realize, it's a bit more complicated than simply a problem with dopamine in the brain, but we know dopamine changes and loss of dopamine in a part of the brain is responsible for many of the motor features of Parkinson's disease. So, of course, in a healthy brain, we know that the chemical called dopamine is an important messenger between brain cells, and that helps regulate normal body movement. In Parkinson's disease, some of those key cells that make dopamine die back or become damaged, and therefore we lose that important chemical regulator in the Parkinson brain. Moving then to more of a description of the symptoms of Parkinson's, listed here are the classic symptoms, including tremor, muscle stiffness or rigidity, and slowness in body movement or bradykinesia. And finally, postural instability, which tends to be more of a later complication of Parkinson's disease. Again, I would try to personalize this. Sometimes this is a time, depending on the group that you're with of patients, you might even ask, who had the tremor as your, notice tremor or shakiness as your first symptom, just to see a show of hands or to kind of start engaging the group so that they can recognize themselves in the condition that you're speaking about.
Okay.
Then we move directly to the treatment of Parkinson's disease. This slide, of course, mentions the most important treatment of Parkinson's, levodopa, coupled with carbidopa. Levodopa, of course, is the mainstay of Parkinson's disease therapy, and by that we mean while not all patients are started on it initially, eventually virtually all patients go on to levodopa therapy, and the majority will remain on levodopa therapy of some type for the rest of their lives. There are other drugs, dopamine agonist and MAOB inhibitors, COMT inhibitors, but I usually tell the patient group at this point that we're going to focus on levodopa in the next couple of slides because that's the mainstay of therapy. Then we go right to off episodes with levodopa. After taking levodopa for some time, for some patients as short as several months, patients may begin to describe on versus off episodes, meaning they notice when their medicine is working and their symptoms of Parkinson's are fairly well controlled, but then they have other times where their levodopa either wears off too quickly or does not kick in properly, and so they experience off time where their Parkinson's symptoms are quite strong. And again, this might be examples, or these might be times where you even give examples from your own work of a patient who recently described on and off to you, and how it affected them.
Right.
In terms of off episodes and when they can occur, these are simply some examples, including wearing off when a dose of levodopa wears off too quickly. Perhaps first thing in the morning, we often use the term morning akinesia for when levodopa fails to work predictably in the morning. Sometimes off occurs as a patient's waiting for the next dose to kick in, so-called delayed on. And unfortunately, some patients have times where they have absolute dose failures, meaning they'll take a usual dose of levodopa and it fails to work at all. I probably should have pointed out, usually when I talk to patient groups, I first start talking about levodopa, I usually do mention some of the other brand names like Sinemet and Evo, or now Ritari as well, because most patients will know that those medications, those brand names, contain levodopa, but don't assume that. Not all patients will know that when we say levodopa, we're talking about a variety of brand name products.
Yes.
And then how do off episodes affect a patient? Again, draw on your own experiences. You're all very accustomed to working with Parkinson patients, so you might give examples in your day-to-day work about how patients have described them to you.
Yes.
Now, this is the first slide that actually has the word APOKYN on it. So these slides, everything from here on, it's really important you cover all the material on each slide and don't deviate from it dramatically. In terms of APOKYN itself, the very first thing that at patient presentations that usually comes up is as soon as they see that word, apomorphine, they say morphine, they think morphine, the narcotic. So I usually point out right away that, no, it is chemically related to what we call morphine in the U.S., the pain medication that is potentially addictive, but it has no addictive properties, and it is not what we call a scheduled medication. In other words, it doesn't need a special prescription because of
That's a good point to even think about. None of my patients asked me that. It was interesting.
That's good. One time, Georgette, one time I was at giving a presentation in Northern California, and I just had a very persistent patient at the symposium who just said, well, how can that be? How can it be called morphine if it's not really morphine? And so I said, it's just the chemical root name. And so I gave him the example, at home you may have a bottle of rubbing alcohol in your medicine cabinet, and then in your den, you may have a bottle of good Scotch whiskey. It would be appropriate. A chemist would say those are both alcohol, and that's true, but you don't expect the same biological effect.
Yeah.
So,
okay, that's a good one.
And actually, people do understand that then, because they understand alcohol is just a chemical description.
Yeah.
Then this is the point in time where I usually say, I think of APOKYN as working like levodopa in a syringe, because that's the other thing. Some patients very often will say, "Oh, an injection. What's that for?" Or it must be instead of my pills, or and they think of it as, or it's going to make me, if I can't walk or I fall all the time, it's going to, it'll help that. But that by saying that it works like levodopa in a syringe, kind of sets up the conversation that it is specifically for the treatment of levodopa-associated off episodes. Then we go right to our label, and we point out from our label that what APOKYN can do for OFF episodes. It can provide rapid and reliable return to an on state. It particularly first thing in the morning if a patient has morning akinesia. It quickly ends OFF episodes, usually within 10 to 20 minutes, and therefore it can help you move about more and even talk and walk better. And, of course, it can be used up to 5 times a day if needed. This slide then just focuses a bit more on the timing of APOKYN, that it can work as early as 10 minutes, and we know that from clinical trials. It usually lasts for 60 to 90 minutes. It can be added to almost any Parkinson's disease treatment regimen. There is no contraindication for the use of APOKYN with any other Parkinson medication. And, of course, because it bypasses the stomach, it doesn't depend on the digestion and absorption of like levodopa tablets or capsules do. Therefore, you don't have to adjust APOKYN around meal times in any way. We added a slide on APOKYN and morning akinesia, and this comes from our a recent Phase 4 study. Of course, morning akinesia is fairly common amongst motor fluctuators. Morning akinesia can be described in a variety of ways depending on the study or the clinician, but generally it can be thought of as when it takes longer in the morning for your levodopa to work than is typical, or sometimes your levodopa first thing in the morning only gives you partial on, or worst of all is when levodopa, of course, has a total dose failure in the morning. In those instances, patients will literally stay in bed until they finally get a next dose to kick in. And, of course, it's that time of the day that we all really want to get up and go, get up and be on, right? Because if you could choose if you could choose a time of the day that your patients could have an off episode, obviously you would choose no time. You'd rather your patients have no off episodes. But if you had to choose a time of the day, it would be, I would think, late in the day or even evening or at bedtime. You certainly wouldn't choose to be off first thing in the morning. That's the very time of the day that all of us want to be up and most active.
Yeah.
So this next slide simply summarizes all the clinical trials. We know that from our clinical trials that in at least 90% of patients, APOKYN provide full levodopa best on effects. In one placebo-controlled study, it effectively reversed 95% of off episodes. And we also know from one long-term study that in most patients, there's no need to increase dosing over time. In that study of patients who on average had already been on APOKYN for over 1 year, when they were blindly assigned to get their regular dose versus an additional dose of 0.2 milliliters, there was no additional advantage to that higher dose, only more side effects. So most patients do not develop tolerance over time to APOKYN. Now, usually, and especially if there's someone in the audience who maybe is on APOKYN, made a dose adjustment, there certainly are individual times where perhaps a patient had to make a decrease in their other Parkinson medicines where an increase in the dose may be needed. But generally, all things being equal, once you find that optimal dose for that patient, that's the dose that they can stick with.
Hey, Dr. Hubbell.
Now we enter those slides I mentioned during the compliance review. These are all the slides that have the important safety information, and they always should be shown. And again, you can point out that all of this information is contained in the written materials that all the attendees will receive. It starts out with the word-for-word indication in patient language. It also talks then about contraindications. APOKYN should not be taken with 5-HT3 antagonists like Zofran, in particular because it is possible, because of the combined effects of these classes of drugs, that there's a higher likelihood of low blood pressure or even fainting. Like all medications, if you're allergic to them, you shouldn't take them. So if you were allergic to APOKYN or any of its contents, you shouldn't take it. And that includes sodium metabisulfite. That's the preservative that's in Apokyn. Sodium metabisulfite is not the same thing as sulfa antibiotics, so having an allergy to a sulfa antibiotic is not a contraindication to the use of Apokyn. Sodium metabisulfite actually is very common, not just in parenteral medications, but also in many consumer products, cosmetics, very often skin toner that women may use, or even some wines contain it, some red wines in particular contain it, and some other food products as well. So in people with true sodium metabisulfite allergy, they should not take Apokyn. They might say, well, how do people know this? Because sodium metabisulfite is so common in day-to-day life, at least in the U.S., virtually all people who have true metabisulfite allergies know it because they've basically changed their lifestyle and know what to avoid in terms of their what they expose themselves to, not having to do with medications necessarily, but even in these kind of consumer products. So it's a very rare allergy, but it is possible. And these patients do know that they're allergic to metabisulfite, and they should avoid this, not only Apokyn, but they need to avoid all products, medicinal products that contain this as a preservative. And, of course, before starting any medication, but including an injectable like Apokyn, it's always important to advise people that they should tell their neurologist about all their medical conditions and all their medications, because I think Dr. Varga can attest, some patients believe that when they're seeing their neurologist, they should just talk about their neurology problems, and they're not always forthcoming, particularly about some of their over-the-counter medications and things that they use, because they don't see that necessarily as a part of their total condition. So it's very important that physicians, neurologists be apprised of all of their medical conditions and all their medicine. There's a reminder in the second bullet that Apokyn is always injected under the skin subcutaneously. I usually compare it to an insulin injection. Third bullet talks about the use of Tygan, that most neurologists will prescribe Tygan to help prevent nausea and vomiting that can occur with Apokyn. The next few bullets, starting with the fourth one on this slide, are what we call class labeling. That means in the United States, the FDA requires certain safety information to be contained in all dopaminergic medications used to treat Parkinson's disease. So these are things that aren't necessarily been associated with Apokyn itself, but are at least theoretically possible because they've been described with other Parkinson's disease medications. So the fourth bullet talks about getting sleepy during the day and falling asleep without warning, and that has been described with dopaminergic medications and is required in safety information within Apokyn. Bullet then at the top of this slide, slide number 18, talks about lowering blood pressure and causing dizziness, and of course apomorphine can cause a lowering of pressure, and so that's the reason we always check the test dose under observation so that the blood pressure can be monitored to make sure that first test dose goes well. The risk of falling with Parkinson's. Yes? Was there a question? In all labels of Parkinson's disease medication, there's usually a comment about the risk of falling, and that's the second bullet on slide 18. Of course, Parkinson's itself raises the risk of an individual patient falling, but the idea that because Parkinson medications, including Apokyn, could make a person feel lightheaded or dizzy, that may actually increase the risk in falling in some patients. Bullet number 3 on slide 18 talks about the potential for Apokyn to either cause or worsen neuropsychiatric problems like psychotic behavior or hallucinations. And again, that's class labeling. All dopaminergic drugs in the United States have a label giving that warning. You can think of it like these drugs can overstimulate other regions of the brain, causing these psychiatric symptoms. And then the fourth bullet on slide 18 is a description of dyskinesia. Those are those unwanted involuntary movements that you usually see, for example, when Michael J. Fox is on television. That is, we attribute to too much dopaminergic stimulation in the brain, and therefore you have these unwanted wiggly or thrashing movements. And that's, of course, a risk with Apokyn, particularly during its peak effects. On slide 19, the first bullet, some people with Parkinson's disease have reported new or increased gambling urges or other behavioral abnormalities while taking Parkinson's disease medications. So this, again, is class labeling. It's contained within all of the Parkinson's disease dopaminergic medication labels. Slide number 2 says that, of course, if you had any type of potential side effect indicating a medical emergency, you should always call your physician or seek emergency medical care. Bullet number 3 on slide 19 talks about the potential risk of melanoma. It's kind of an interesting issue in Parkinson's disease. It is, when studied, it appears that Parkinson patients, as compared to the age-matched general population in the U.S. at least, has a higher risk of developing melanoma. It's not really understood if Parkinson drugs then can increase that risk. But again, this is class labeling. Every Parkinson's disease medication says that that risk is possible, not well determined, but possible, and therefore we always advise all Parkinson patients to have at least annual skin checks. And then at the bottom of slide 19 is simply the most common side effects seen with Apokyn in clinical studies. Slide 20 talks about that some patient may have injection site reactions, and we believe that changing the injection site, rotating the site of injections, helps reduce the risk of that. On slide 20 in bullet number 2, some people may develop depression while taking Apokyn. That, again, is class labeling for all Parkinson's disease medications. It's interesting because dopaminergic drugs have both been reported to be mood elevating, meaning having a mild antidepressant effect, but conversely, in some patients, having a mood depressing effect. So this, again, is class labeling and not specific to Apokyn. Finally, in terms of the last bit of safety information, bullet number 3 on slide 20, because Apokyn has not been studied specifically in pregnant women or nursing females, we don't really know if it has effects on a pregnancy or on breastfeeding. Of course, in the case of Parkinson's disease, simply because of the age group most affected, this generally is a moot point. Bullet number 4 on slide 20 explains how to report a suspected side effect, or if they have a complaint about the product, they can directly call us at a toll-free number, or, of course, you can always report such things directly to the FDA. So now we're in the last section of the deck. We're almost done. And this is about how to use Apokyn. And I know all of you know this quite well. It just reiterates that it can be used up to 5 times a day, that it's much like an insulin injection. And it gives some examples of sites of the body where it's easier to give the injection subcutaneously. And that either the patient themselves, depending on the circumstance, or their care partner can give the injections. We actually know from data from our Circle of Care nurse team that approximately half of the current Apokyn patients in the U.S. have a care partner who either injects all the time or some of the time. But so conversely, that means that about 50% of our current APOKYN-treated patients in the U.S. always just inject themselves. They never rely on a care partner for their injections. This now is starting the conclusion part of the talk. It's who is an APOKYN candidate. It just takes us back to that same slide about a description of OFF episodes, and that it's specifically for OFF episodes that patients may want to consider and with their physician APOKYN therapy. And then we have embedded in the slide deck an APOKYN patient video. And then on slide 24, it steps through what it's like to start APOKYN. And again, what I would usually do in this circumstance is I talk this through, but I also get the account manager involved in some of the logistical issues. I always instruct our regional account managers never to make a comment about safety and efficacy of APOKYN during these types of talks. But once you start getting into the logistics of how the drug, is shipped by a specialty pharmacy, or if it's not a Circle of Care nurse who's making the presentation, talking about how the Circle of Care nurse gets involved, it's absolutely fine for our account managers to be involved in that part of the presentation. Including on slide 25, it shows all of our Circle of Care support programs, including the Circle of Care nurse services, the role of the specialty pharmacy in delivering APOKYN, and also the referral to financial assistance if needed. Slide 26 simply summarizes the Circle of Care nurse services, and of course for Circle of Care nurses who are on the phone today, you can simply give examples of the type of work you do in your day-to-day activities. Slide 27 summarizes our financial assistance referral programs, and again, the account manager can speak well to these. Slide 28 simply is a conclusion of everything we just gone over. And then that's it, slide 29, just to set up a queue to you to ask for questions. And I'd be happy to answer any questions that you all might have.
Dr. Hubbell, this is Colleen. You had said that during the presentation that we may be able to pass out some literature to the patients. How do we get that information?
Right. Your regional account manager will have those. We have specific literature prepared by the company for patients, and those are always to be handed out to all the attendees at these programs. Again, like the slide deck itself, those materials have all been filed with the FDA, so it's important that we use those materials and not some other, and not make up anything new or, provide other supplemental materials. Now, sometimes the support groups themselves, especially if they're affiliated with a national organization, they may have their own, separate from APOKYN, they may have their own educational brochures that they provide at all of their symposia or support group meetings. So I don't want to confuse the two. Anything that support group provides, that's certainly fine for them to do so. It's just that we, representing U.S. WorldMeds, we can only give out our approved materials.
Okay, thank you.
Sure.
Dr. Hubbell? Dr. Hubbell?
Yes.
Hello? Hi, Georgette here. So I have a question. I had patients with orthostatic hypotension. I'm starting to use Nortera, and they do quite well. Will there be any contraindication, or should I be cautious about using Nortera and probably APOKYN in the same patient?
No, there is no contraindication to the concurrent use of both.
Good, great, because I'll try APOKYN. I had a patient that is now much better. He's less symptomatic. With Nortera, he was very orthostatic, and he has a lot of feeling of gait. He's advanced. He's older, so I'll try APOKYN.
Very good. And for some of our nurses on the phone, I may mention the point that Dr. Varga brings up. there's another drug on the just relatively recently on the market, and it's not to treat the motor symptoms of Parkinson's disease, but it's intended to help with blood pressure, raising blood pressure, because low blood pressure in Parkinson's disease, particularly orthostatic drops in blood pressure, is a common part of the disease itself. So separate from our medications, including apomorphine, Parkinson patients may have orthostatic hypotension that is so problematic that it requires separate medications to successfully help them maintain adequate blood pressure.
The reason I said that because sometimes that in the past, before Nortera, would have prevented probably enrollment of patients in the Apokyn trial. Now that we have Nortera and some of the patients do improve symptomatically in orthostatic hypotension, I'm not going to hesitate to enroll them in Apokyn. I remember when I was at Cleveland and we started to use Apokyn at that time, we had problems with these patients with orthostatic hypertension. So,
it's an excellent point. Thank you for bringing that up. That's an excellent point, and a good, I think, good for our Circle of Care Nurse team to hear more about these other helper drugs. Any other questions?
I just have one more question. In the safety information, it says, tell your healthcare provider about your medical conditions such as low blood pressure, asthma, liver problems, kidney problems, etc. And me being a Circle of Care Nurse, I have a lot of patients say, well, I do have asthma. Is it okay that I take the medication? So is it basically that we want to get everything cleared and everything is stable before they take it? How would you respond to that?
Yeah, so it's not because Apokyn is not contraindicated in any of these other medical conditions. The only strict contraindications are the ones highlighted on, bolded on slide 16, meaning don't use it along with 5-HT3 antagonist, don't use it if you're allergic to sodium metabisulfite. But the reason that we caution individuals about making sure their prescribing physician, meaning their neurologist, knows about all their medical problems is simply because it's in that best judgment of the prescribing physician as to should we be more cautious with Apokyn? Should we even start at a lower test dose? You can start at 0.1 in certain circumstances, but that's really up to the prescribing physician. So it's simply important that the prescribing neurologist knows the entirety of the patient's history. As I said, at least thinking back when I was still in practice, every once in a while I would see a patient for 2, 3, sometimes 4 or 5 times before we'd finally figure out, they were on a bunch of different vitamins and other, over-the-counter nutraceuticals and things. So sometimes patients can be, because they're so focused when they're in the neurologist office on their Parkinson's disease, and that's understandable, it is surprising how sometimes they can omit key pieces of their current or past medical history. So it's really around that, not because any of these one specific things are contraindicated with Apokyn. Did that answer your question?
Yes, it did. Thank you.
Any other questions? Well, what will happen next are a few things. I'm going to send an email today to my colleagues who help organize these programs, and we'll also let your account managers know that you're trained as a patient program speaker. And in Dr. Varga's case, she'll be paid for this training session this morning because of the time. Again, this is an FDA-required training. And the same to the Circle of Care Nurses, you'll be paid through your usual reimbursement plan through Impeccable. And then you'll hear from your account managers, and they'll be working with you to set up programs in your area. I just want to make sure. Well, a couple of things. I want to thank you for taking time out on a Friday morning to go over this. But the other thing I'd like to make sure and do is urge you, if you do have questions that come up as you either are planning one of these programs or after you've completed one, you think there's either something we could do better on our end, or you just have a question about how could I have handled that question differently, please feel free to reach out to me. Please let me know. And again, these are considered promotional programs, so it's absolutely fine for you to talk it through with your account manager as well, because when all is said and done, yes, we're in business and we do promote the use of APOKYN, but we want to do so safely and effectively for our Parkinson patient population. So it's really important for you to give us that feedback.
Yes.
And I'll conclude with, and thank you again very much, all. Have a good weekend.
Thank you so much.
Thank you.
I'll see you then, Dr. Hubble. Thank you.
Thank you.
Bye.
Thank you. Thank you very much.